everyone. A very warm welcome to the FHS seminar. I'm here on behalf of my colleague Salim Hanoun, who helped organize this seminar, but unfortunately he couldn't be with us today. I want to welcome those of you who are present in person and those who are with us online. This is a hybrid event today, so just a brief shout out to our colleagues who are online. If you are having a hard time hearing us, please let us know. Send a note in the chat or speak up right now if the sound is not clear or if the quality of the slides are not clear. Well, this has not been a problem before, but if you're encountering a problem, we want to help solve it so you can have a pleasant webinar experience. So today it's a real pleasure to welcome our homegrown colleagues in the faculty. We have two of our own from two different departments. Sawsan Abdulrahim is associate professor in the Department of Health Promotion and Community Health. You know, it has two health, so they always have to think about which one comes first. She's someone with a long history of work with refugees, vulnerable communities, and social determinants of health. So this area is a core area. She is the PI on the projects that is being presented today. We also welcome our colleague Steve McCall, who is assistant professor in another department, health, epidemiology and population health, and who is the acting director of our Center for Research on Population and Health, CRPH. So today, their topic is changing vulnerabilities, adherence to COVID-19 measures among Syrian refugees in Lebanon. Sawsan and Steve will speak for about 30 to 40 minutes, and then we will open for Q&A. For those of you who are online with us, please submit your questions. Colleagues, submit your questions in the chat box. We will be monitoring that and getting hopefully to all of your questions when our speakers conclude their contributions. Okay, so without further delay, Sawsan and Steve, thank you for joining us today. Thank you.
Hello. Yeah. Okay. Hi. Good afternoon, everyone. It's great to see so many people on Zoom, but it's also strange to have so many people on Zoom and a smaller number of attendees in person. So thank you very much for the invitation to talk about, to present on this study. Today, Dr. McCall and I are presenting on behalf of a large group of individuals who worked with us on this project and who have come in and out, and some of whom stayed with us throughout the whole process. I want to mention that this study is in collaboration with the Norwegian Refugee Council. They were supposed to be, our colleagues are supposed to be here today with us. Maybe they're at the door being, they're online, okay. Okay, great. I want to say also that this study was funded in spring 2020. Shortly after the corona epidemic began. It is one of a cohort of 15 studies that were funded to do a rapid assessment of COVID in humanitarian settings. And of note, it's important to state that this study is one of 4 that have been funded in our region, and it's the only study that is led by researchers from the region and not from the US or the UK. This is important to note. The title of my talk is, of our talk is Changing Vulnerabilities, Adherence to COVID-19 measures among Syrian refugees in Lebanon. These are our Twitter handles. If anybody would like to follow us on Twitter, please do. Okay, so for anyone who doesn't know yet, there are Syrian refugees in Lebanon, and the number of refugees ranges between, depending on who reports the number and for what purpose, between 1.5 million and actual number that's reported on the UNHCR website is around 840,000 refugees. Syrian refugees in Lebanon encounter exclusion and marginalization for various reasons related to the history of the relationship between Lebanon and Syria, in addition to other factors. In addition to that, they've also, like the Lebanese, they have also been suffering or basically marginalized due to the compounding impact of the economic crisis and the COVID-19 pandemic that basically took place at almost the same time. So this is one of the reasons why when the funding by ELRHA was announced, we felt that it would be really interesting to address underlying and emergent vulnerabilities that impact older Syrian refugees in Lebanon. We were actually invited by the Norwegian Refugee Council to collaborate with them on writing the proposal for this study. So these are the objectives of the study, and I actually have to read those. But the first objective is to assess how barriers, facilitators, and vulnerabilities are associated with adherence to COVID-19 preventive measures. The second objective is to look longitudinally, actually, and to follow the pandemic, and to examine how adherence to COVID-19 preventive measures would vary over time in response to change in underlying and new emergent vulnerabilities that come into place. The third objective, which is really important for us, is a programmatic objective. And it's really also important because of our collaboration with the Norwegian Refugee Council. And the objective is to inform humanitarian programming in response to COVID-19 and older Syrian refugees. The idea is to provide almost up-to-date, almost in real-time evidence and feed it into the Norwegian Refugee Council program so that they can adapt and respond better to COVID-19. And hopefully also the learning process will prepare them better to respond to other emergent crises. We're talking about cholera right now, for example, as a health crisis that hopefully some of the lessons we learned from this study would support a better response or quicker response to other crises, health crises in the future. So we'll talk a little bit about methods. I'll start and then my colleague Steve will continue. But our sampling frame was actually, this is, just let me mention that this is a quantitative longitudinal study. So we have a large sample. We'll mention the sample size and other things in a few minutes. But our sampling frame was actually all refugee households that have received assistance from NRC. I'll just start to use NRC for Norwegian Refugee Council. All refugee households, 17,384 that have received assistance between 2017 and 2020, and that had one member of the household older, age 50 or older. So this is a large sampling framework, and actually, the data collection company that we worked with, actually the methodology involved household surveys completed over the phone. The data collection company that we worked with called every single household out of the 17,384 in this sampling frame. So I think one of the reasons why this study was funded is because of the innovative methodology that we proposed, and it's really not my work. It's I liked it a lot, and I learned about this methodology. But basically, the idea is that by doing what's called a multi-wave rotating panel longitudinal study, we would actually follow the timeline of the how the epidemic unfolds in Lebanon. So the epidemic is unfolding over time. I don't know why that's that. The epidemic is unfolding over time, and different things are happening in the environment. We have a lockdown and then the ease of a lockdown, and then at some points in time, humanitarian organizations provide cash assistance to refugees. And then there's another lockdown, the ease of lockdown. And then there was a time when basically the vaccine was approved and people started to register on the Ministry of Public Health application to get the vaccine, and then the vaccine became available. So throughout this whole time, we're actually, what we are doing is we are collecting data on a rotating manner, in a rotating manner. We started out with wave 1, and each wave had 3 panels. It's basically the big sample size divided into 3, panel 1, panel 2, panel 3. So in wave 1, we would collect data on starting with panel 1, panel 2, and then immediately after completing panel 1 and starting panel 2 for wave 1, we would start panel 1 for wave 2. Okay, so we're constantly collecting data as things in the environment and related to COVID are changing. So we collected, it's not working now. Okay. So we initially proposed to collect 4 waves of data over the course of 9 months, in between like an 18-month funded study. However, by the time the vaccine arrived and people were getting ready and were receiving the vaccine, we had completed the data collection for wave 4. Luckily, we had some funding left because of the economic crisis and because of the change in the dollar exchange rate. So we had some money left and we requested a no-cost extension. We collected an additional wave of data after the vaccine was being rolled out. And you'll find out from the presentation by Steve now why this was a really good idea to continue to collect data for wave 5, sorry. So I'll hand it over to Steve right now. Do you want to click those?
Sure. So we were really concerned about making sure that our data collection tool was really relevant to all the stakeholders, including NGOs and their beneficiaries. So we really wanted to include all our stakeholders in that process. And so we started with obviously literature review to get a number of modules that we thought were interesting and relevant to the crises. We engaged NRC in a number of extremely long meetings to make that questionnaire shorter. And then NRC took this questionnaire to beneficiaries and community focal points to make sure that it was really relevant. We reached consensus and then piloted this amongst our study population to ensure face validity. And then the questionnaire was translated into Arabic. It's not working. There we go. So we designed the study to be a telephone survey so that we could almost overcome the difficulties that were to arise from May 2020 onwards. We didn't know what the future held for us then, so telephone surveys was the way to go. And with telephone surveys, we're pretty concerned about data quality. So we did everything that we could to ensure high data quality. So we recorded the data collector interviews to ensure the interviews were being conducted accordingly, data quality checks almost on a daily basis by our research team, and weekly meetings with our data collection company just to make sure that everything was as we wanted. Ethical approval, we had 3 layers of ethical approval almost. We had IRB from AUB, NRC gave a fantastic presentation on protection, and we followed this excellent toolkit by ELRHA on research ethics when working in humanitarian settings, something to bear in mind for future studies, a very good resource. So these are the modules that we collected during each wave, and they varied because, as you know, it's quite difficult to collect a large amount of data across or through a telephone interview due to time. So we had to be quite strategic with what we collected. But in general, we collected, health, shelter, livelihoods, food security, and issues related to COVID. So the sample size, so we called around 18,000 households. As I found out during the study, is that many of those numbers were incorrect, or numbers had been changed during that time. And so so we had to call 17,000 in order to get 4,000 to respond. And we had not a bad rate. So we ended up with 3,000 at wave 4, and then we resampled those who gave consent at wave 1. So that's why we got a higher number in wave 5. So I'm going to hand back over.
Yeah, okay. Okay, so we'll present to you some of the outputs or the results from this project. Of course, we're just starting. We have just started, and Steve has been very active in working on papers. Well, first, let me present to you some of the characteristics of the participants. This is a relatively young, old population. So the median age was 57. The range was broad. I mean, was from 50 up to 90 years of age, but the median was around 57. The sample was good in terms of representation of women and men. As we found in many other studies actually on refugees, this is a population that has a relatively disadvantaged educational profile. It's not representative, of course, of the Syrian population. It's just, this is the population that is receiving assistance from a humanitarian organization. Almost half have never attended formal education. And then almost 40% live inside tented settlements, whereas in the general Syrian refugee population, a much lower proportion of refugees live inside tented settlements. So we're starting to work on academic papers from this project. We have a couple that have been published, one just recently published in the JAMA Open Network, and we have a couple that are being written and finalized as we speak this week. And then, of course, we have a list of other papers that we are working on. And also, we've made the data available for students who are working with different collaborators and to work on the data and publish on mental health, for example, or on cash assistance and other issues and other data that we have from the study. But what I think is really important to mention is the programmatic outputs that we have also invested quite a bit of time throughout the last year producing, mainly for the humanitarian community in Lebanon in terms of snapshots and presentations that we've done in different venues in the National Health Working Group and the National Food Security Working Group. And we've also produced some snapshots for the humanitarian community, but also we produced output for the community itself, particularly some outputs that we felt were really important to disseminate, immediately to intervene as soon as we find some gap in the data. Then we feel like we need to intervene immediately and disseminate certain type of information in order to protect the community. So what I want, this is one of the snapshots that we produced, but what I want to show is one out of, where's the clip? Yeah. 1 out of 3 videos that we produced.
فيروس كورونا كتير صغير وما فينا نشوفه بس فيه يفوت على جسمنا ويخلينا نموت. أعراض الكورونا هي الحرارة، الصعبة، سيلان بالأنف وتعب كتير. وانتبهوا كتير إنه المضادات الحيوية ما بتمنع الانصاب بهالفيروس وما بتعالج المرض. فينا نمنع انتشار الفيروس بس نغسل إيدينا دايما بالمي والصابون، ونلبس الكمامة على التم والأنف، وما نزور أشخاص من خارج العالم. فيكم تحموا حالكم وتحموا اللي بتحبون من كورونا.
Okay, so this 30-second video or something. This was produced very early on, actually, in the middle of wave 1, where we discovered that a lot of participants are reporting that they use antibiotics, or they think that if they catch COVID, that they can use, that using antibiotics would be a good treatment. So we immediately designed this video in order to address this in a short video about washing hands and wearing the mask, but we thought highlighting the issue of antibiotics not being a good or effective treatment for COVID. We have a couple of other videos as well and a couple of other outputs for the community that we produced. Oops. Okay. So I'll talk about one of the papers that we are currently working on, and this was supposed to be one of the earliest papers that uses cross-sectional data to examine the multiple determinants of adherence to the preventive measures of COVID-19. So in this paper, and this paper is utilizing data from the first wave, actually, during a time when people were still getting used to wearing a mask and the idea of social distancing, really new ideas, new concepts of preventing an infectious disease. So what we looked at basically as outcomes are mask wearing and staying at home, two different outcomes actually. And our data confirmed that these are two different outcomes and should not be studied together as like adherence to COVID in general. And we are utilizing some concepts from health promotion related to how knowledge and perceptions of threat and barriers influence people's decisions to engage in behavior. But because there's ample literature that highlights the concept of the knowledge behavior gap, where people's knowledge does not necessarily determine or is a really weak, in many cases, is a weak determinant of behavior, and that it's really important to understand what are the other psychosocial or structural factors that would influence people's adherence with certain behaviors. So we developed this model whereby the outcomes are determined by these constructs of knowledge and perceived threat and barriers, but also that these constructs are couched in a structural context. And we basically tried to capture the structural context through measures of education, the level of education of the individual, where the individual resides, and the assets, a measure of assets, assets as a measure of wealth in this community. We used what's called path analysis in order to really examine how the structural variables determine the knowledge and the psychosocial variables, which in turn would determine adherence to behavior. We built two path models, one for mask wearing and one for staying at home. We did not look at hand washing because it was universal, and also because there's an issue in many situations, refugees feel offended every time humanitarian organizations focus on hand washing. This is happening right now with cholera, where hand washing is people are bombarded with this message of wash your hands, but then the water is contaminated, the vegetables may be contaminated. So anyways, we're not looking at yes, we look, yes. So it's the idea is not whether you wash your hands or not. We looked at water security. And we'll show a slide at the end. Yes, so that's a very important question. So don't worry about these lines and these numbers, but I'll tell you what the results are, and just trust me. So basically what we found is that education is the most important predictor of adherence to preventive measures in the context of forced displacement setting and in the context of a crisis, a health crisis. Education predicted directly both mask wearing and staying at home, and it predicted mask wearing indirectly through knowledge. So knowledge is, it's not that we're saying that knowledge about COVID specifically is not important, but that knowledge is also determined by a person's level of education. So that's why our title is Changing Vulnerabilities with a question mark. You know, there's nothing exotic about education being a fundamental cause of health behaviors and health outcomes in general. It is an enduring measure of socioeconomic position. And in this case, it shapes risk not only through knowledge about COVID, but also directly between education and mask wearing and staying at home. And another important finding we have is that all the refugees who live outside tented settlements, which are generally, we think that those who live in inside tented settlements are more disadvantaged, but our results showed that those who live outside tented settlements actually were less likely to adhere to mask wearing and staying at home. So now again, we shift and present more interesting results.
So a number of colleagues in our faculty have been raising the issue of the management of non-communicable diseases in being a neglected topic in this population, particularly in Syrian refugees and humanitarian settings. And so we were particularly concerned about NCDs because, one, this is an older population, so they have a higher prevalence. Also, due to the lockdowns, there may be accessibility issues. And also, as we all know, the NCDs are a risk factor for mortality and morbidity from COVID-19. So we had, let's present some results here. Out of the 3,000 participants who responded to this wave, around 40% had hypertension, a quarter had a history of cardiovascular disease or diabetes, respectively, and about 10% had a history of chronic respiratory disease, which is quite similar to what you'd expect in this older population. And out of those who had one NCD, 20% said they were unable to manage their NCD either through lifestyle measures or medication. So it's actually quite a low prevalence compared to what we think. But 20%, you know, it's quite a high number maybe. When we then asked them about their NCD medication and reasons why, on affordability, accessibility, and feeling better were the main reasons that came to light. And inability to access primary healthcare was related to costs of visits, medications, or tests. But during this period, which is quite interesting, was that NCD medications were free of charge from a primary healthcare centre. So maybe this is costs related to transportation, and other accessibility issues. Maybe we can have a discussion around that afterwards. We then decided to build a predictive model, so a prognostic model, to give an idea of and provide humanitarian actors with a risk prediction for each individual according to different characteristics. So this model retained age, receiving cash assistance, water insecurity, food insecurity, and having multiple chronic diseases. So what does that mean? Well, I'm going to try and contextualize that. So let's think about an individual. So an individual aged 60 years or older who had all 4 NCDs, had severe household food insecurity and water insecurity, and didn't receive cash, would have a predicted risk of not being able to manage their NCD at 51%. So if we contrast that to somebody who had 2 chronic conditions, was food insecure, cash assistance, and had water security, their predicted risk would be 9%. Obviously, if they had less chronic conditions, this would be lower. Just to give you an idea, so we produced a prediction model for humanitarian agencies to use. Since we're amongst academics, we should always present our model performance. The model had a moderate discriminative ability, and this is a calibration plot. So what does this mean? So a perfect calibration in your model, you'd expect your predicted risks to equal the observed. And so you'd expect a nice perfect line. So what we did was we internally validated our model. What does that mean? That means that we want to ensure that when we take our model and apply it to new data, that it works as we expect it to. What we know is that when we develop models, they tend to be slightly over-optimistic. So we want to produce an unbiased model, so we internally validated it. And it's not too bad, because all these dots seem to be quite close to the line. There isn't really any high predicted risks. And so this calibration slope means that when we take this model and apply it to new data, we expect it to over-predict the extremes by around 13%. So that's not too bad. Sure. So COVID-19 vaccines, it was really excellent to get an extension in order to study this, because our study was meant to end in May 2021, which by that time, not many people had a vaccine. So we were extended for another year, which is fantastic. And which was also really cool was we were able to measure intention to vaccinate in wave 3. So we asked everybody if a vaccine was available, would you take the vaccine? Yes, no, maybe, no. And then a year later, we asked them whether they had received a vaccine. So we're getting what their attitude to the vaccine was a year before and their actual behavior a year later, which is quite neat. And so if we follow this blue box, so this is among those who said they would the vaccine, and then their actual behavior. So 60% said they would receive the vaccine, and then 45% of those ended up receiving the vaccine. We follow the yellow box, which is those who said they would not take the vaccine. A third of them ended up receiving the vaccine, so a change in behavior. Yeah. So looking at those who received the vaccine, we then asked them some questions about why they hadn't received the vaccine at different stages. So, so those who received the first dose, 42% amongst the whole population received the first dose, 60% did not receive. The main reasons were they didn't want to take the vaccine, side effects, and interestingly, 20% said they were still waiting to be called. So among those who had received one dose, and still waiting for their second, we can see that the main reason they haven't received their second is that I've registered, but they did not send me the message. So they're still waiting to receive the vaccine. This was in May 2022. Again, we created 2 prediction models to understand what were the key predictors of vaccine intention and then actual uptake. So age, sex, education, residency, and beliefs about the vaccine and where one receives the information about COVID were all predictors of intention to vaccinate. Uptake, same variables, but we also included intention. So whether somebody's intention is a predictor, and it is. And this one has a better model fit than our previous model. You can see this is a really nice straight line. And I'm going to hand over to present some of the longitudinal analyses.
Oh, 7 minutes, that's good. Yeah, I'll just run through very, very preliminary longitudinal findings from the study. Very basic, really. What we're looking at is really for a lot of the outcomes that we have that we're interested in, how things change. So the vaccine intention, vaccine acceptance, vaccine uptake is one of the things that we are looking at longitudinally, but also we're looking at self-rated health between wave 1 and wave 5, mental health. And as you see in this very simple, these 2 simple graphs, that self-rated health and mental health, good self-rated health and mental health has gone down over time, over the course of 1 year between wave 1 and wave 5. We also see that the assets that individuals are reporting have gone down, an indication perhaps that people have sold some assets to get cash to buy basically essentials. Not that some assets are essentials as well, but maybe to buy food. And what we find when we look at different types of assets, transportation, cooking, technology, and communication, what is interesting to see is that the people have not sold any, like have not sold their cell phone, but have maybe sold transportation, a moped, or something that they used for work, for food delivery, or I mean, this is an older population, but this is household assets. So again, it's important to, we see this in different studies where refugees invest in maintaining communication with relatives and family that are dispersed in different parts of the world. And so that cell phone and the data that they purchase for communication is very important. And that's something that they would not give up on. We looked at food insecurity. This is the area of Dr. Hala Ghattas's research. And in wave, at the time we were collecting data for wave 2, humanitarian organizations have given some cash assistance to refugees. So we see here that severe food insecurity reduced from 45 to 32 over the course of a couple of months, basically because of the cash assistance. But then it gradually, severe food insecurity gradually increased over time. This is basically work that our colleague Zaina Jamaluddin, who used to work at CRPH, has done, which is looking over time at water insecurity by season. I mean, this is very almost common sense that, you know, in August and September, you see a lot more dark colors that indicate more water insecurity. And then with the rainy season, December and January, the color, basically food, people have less food insecurity, but then it increases. Did I say food? Water insecurity, yeah. Okay, so basically to wrap up, what is the outcome of our study is that we've produced local knowledge. This is like a cliche almost nowadays, the production of local knowledge, a study that has been designed here and that has been actually, it's almost like an implementation study where we've made changes along the way in response to changes in the context and the environment. A very important part of the study is the basically production of data that we fed in almost real time to the humanitarian community, particularly the Norwegian Refugee Council, but also through our meetings with the different humanitarian sectoral programs. With respect to our research findings, basically based on the papers that we presented now, it's really important to keep in mind that education is an enduring measure of socioeconomic position, and that even in context of displacement, in context of crises, education as a resource is important as a protective determinant. In this case, education was very highly predictive of adherence to COVID preventive measures. With respect to chronic diseases, there's a need for availability and accessibility of chronic disease medication. Basically, that's what the study found. And then with respect to vaccines, there was basically an immediate response at the beginning of the pandemic and later on when the vaccine became available, that Syrian refugees don't have accessibility and don't believe in the vaccine, don't believe in COVID, and are not going to be vaccinated. And the idea here is that we really need longitudinal data to understand the dynamics of vaccine uptake. It's not enough to rely on intention or to collect data early on when a new vaccine becomes available. Vaccine uptake is a complex phenomenon, actually. So I'm not going to go over limitations and strengths. These are some of the academic outputs we have. And I just want to end by acknowledging, first of all, Branded, the company that helped us produce the animations, BOT, the data collection company that we worked with, and of course the community and the participants in the study. And these are all the names of all of us who have been involved in the study. So thank you very much. And we open for questions.
Okay, thank you very much. This was an amazing study that covered a lot of grounds. Before I open the space for Q&A, let me invite our colleagues from NRC who might be present in person or on Zoom to join us in providing their feedback about what this study has meant to them. Are any of our NRC colleagues online?
Is Zainab Ramadan.
All right. Would you like to comment and make any comments? I don't mean to put you on the spot. If you don't feel like you'd like to make any comment, that's okay. I assume they hear me.
Hello.
Hello.
Yeah, it's Marwan. Thank you for mentioning this. Yeah, there's
Marwan.
Actually...
Can you please introduce yourself?
Yeah, I'm Marwan, Alawi Research and Evaluation Advisor at NRC. We've been working with the research team from AUB on this longitudinal study. And there are some colleagues also on the call. It's a really good summary, interesting results presented by Dr. Sawsan and Dr. Steve. Yeah, I would probe from my side on the importance of such a partnership between AUB, academic institution, and the humanitarian actors on such topic, which bridges some of the gaps in making better access for data and generating outputs of that. And some of those were presented today in the slides. And most importantly, feeding into the body of literature through peer-reviewed journals that, as Dr. Steve mentioned, are being upcoming for different topics.
Thank you. All right. Let's go right now in alternative way with a question from the floor.
Perhaps. Can you hear me?
Thank you for introducing yourself. It's important that everyone does that.
Yeah, I realized that we have it.
It's perhaps it's not the best sound quality.
Thank you, Samer, and thank you for the presenters, and thank you for presenting this important study that was very timely, that was very important for FHS, and for collaborating with the NRC, because it's very important to extend the hand with NGOs who are working in the communities. I have a logistic question, and that's regarding sampling. Perhaps Steve, you can answer this question, or probably people from the NRC. You presented to us that the proportion of people who are living in ITSs and people who are living outside of the Syrian refugees. I'm interested to know what's the difference between this population, when sampling this population, and the UNHRC, for instance, service population. Like how different are these two populations? What are we missing by just going to the study population that NRC services, for instance, and because this would reflect on the upscalability, generalizability, and things like that. I realize that you're only studying the older adults here, but it's still important to know the difference. And we did not see this in your presentation, if you can elaborate. And if you can put in the meantime the study limitations, not to go over them, but just to look at, if possible, on the slides. Thank you very much.
So very good question. And in fact, that's a question a peer review asked us when we published the JAMA paper. And we then published alongside that the proportions of different characteristics and how that compared to the VASIR. Obviously, the VASIR is a representative study on Syrian refugees. Short answer is that they're probably going to be quite similar if they're receiving assistance from NRC and UNHCR, because they're both receiving assistance. But you have to remember NRC, maybe our NRC colleagues can interject, provide assistance in terms of housing, legal, protection. And so that, and I don't think they do food and cash assistance as well. So that then will, if a beneficiary receives those, that will then impact who's in their listing, as it were. So that's something really a good point to bear in mind when we're working with NGOs. What assistance do they provide, and then who becomes their beneficiaries, and how is that different to then the UNHCR beneficiaries? They're slightly different, but you know, I would say they're similar in the fact that they're both similar proportions in terms of cash assistance received between our population and UNHCR.
I just want to say that it's not possible to have a good sampling frame for refugees. So the VASIR is actually with registered refugees who are registered with UNHCR. So it's also not representative, because those who are not registered with UNHCR might be, we don't know, maybe they can be more disadvantaged, or they can be less disadvantaged, and that's why they don't need UNHCR's protection. Or so it's very difficult. And yes, of course, you know, when you go with the beneficiaries list of a humanitarian organization, I mean, it's very difficult to say that the results are representative, but it's the results that we have. Yeah.
Thank you. We have several questions from colleagues on Zoom. Clarification. First, I think the vaccine, because so they want a competition. Number two, we have to elaborate the type of statistical assistance and tools used in the study.
Okay, so yes, I think UNHCR and NRC, because of their presence among refugee settlements, they were collecting data on the misinformation, the infodemic about, you know, things related to, you know, the vaccine will affects fertility, affects hair, you know, it's not effective. All of these things about the vaccine. Our study, we really didn't get into it. I mean, even the knowledge questions and the perceptions that we included, we basically tried to capture whether people have accurate or inaccurate knowledge about COVID itself. And we asked whether they think the vaccine is effective, and if the vaccine is effective and is provided for free, whether they would take it or not. So we didn't get too much in our study into misinformation about the vaccine.
Okay, thank you.
With respect to the
type of statistical analysis tests and tools, I do believe that you covered some of that there, because you spoke about various things. Perhaps you want to elaborate a little bit further.
So we go from the simple to the complex, and at CRPH we're really keen about building capacity in our research team. So during this study, we had training to go on prediction modeling courses and longitudinal analysis courses. So it really depends on the study. You can check out the ones on medRxiv and the published ones. So each study will have its own statistical analysis plan that we used. It was really quite interesting to see the types of analysis that we did for the cross-sectional, from structural equation models to prognostic models for the NCD. So lots to learn and really quite innovative.
Thank you. So another question from the floor. If you could please introduce yourself.
So hi, Grace Khawam from HPCH. And so thank you so much, Stephen and Sawsan, for this very rich and meaningful findings. I just have two questions, actually, kind of linked together. So did you, when we think about older age, did you look at intersectionality with disability? Because a lot of the time there is co-occurrence with visual impairment, cognitive impairment, mobility issues. And so these can also be barriers to access and to want to get a vaccine, and that would affect also health behavior. And so, for example, one of the things that we looked at within the Disability Hub, which is like working on advocacy for disability rights and inclusion within the vaccine response, if we can call it, was, the information that was received a lot of the time was not accessible for people with different types of impairments. The centers where the vaccination was happening was a lot of time also not accessible, and also how to register on the platform. A lot of people were, like, especially in the older age group, did not find it easily, to navigate and to actually register. So I just wondered if you had that, looking at that in your study. And the second thing is just a tiny comment linked to the first, which I really, really appreciated the community engagement and the video where you felt that, okay, we just need to address, the lack of information, or in a very visually and accessible manner, because there was also no words. And, you said that the majority did not have access to proper education. So I felt, I really appreciated that. Just a tiny comment, color contrast. So just also because people with older age might also have visual issues in terms of color blindness, I felt that in the video, the color contrast was just, not fully accessible. That was just my comment.
Who wants to take this?
No, this is absolutely excellent. I mean, we're also working with Dr. Monique Shaya on...
You can raise, some colleagues yes, exactly.
Yeah, so absolutely. I mean, any study on older adults has to engage with disability. We included in the ELRHA questionnaires the Washington list of questions on disability. They're very basic. Yes, but it's always when building a questionnaire, people fight to get all the questions that they want in. But I mean, we can talk with you about these questions and how we can make use of the data on disability, and maybe linking it to access to services and access to the vaccine for sure. Yes, and the color, yes, absolutely. Actually, when we developed these videos, at the beginning, we thought they were really nice and great, but then we received some critique afterwards. But still, we had to produce something very quickly to say something about antibiotics, to say something, in the other two videos, each one had its specific message as well.
So NRC disseminated through their WhatsApp groups with their beneficiaries. We also had it on the UNHCR's Facebook and Twitter page, which has a huge number of followers. I think that, yeah, mainly WhatsApp and social media.
Back to the online questions. We have a question, two questions together from a colleague. Have you considered carrying out a study like this among a similar Lebanese group? Number two is that, can you give examples on how the findings were translated to actionable steps?
There's a call for research on COVID in humanitarian settings. And yes, honestly, you know, humanitarian setting would also include Lebanese who live in the same area, who are also impacted by water insecurity and by other factors. Unfortunately, no, we only focused on Syrian refugees.
With regards to actionable steps, we asked in wave 3 about registering for the onto CUVAX, and there was a really low registry rate among Syrian refugees, and we disseminated that back to WHO, which fed into part of their action program for that. And I think then, due to us, and I'm not just us, I'm sure a number of different people finding the same information, they then went to the field and had mobile clinics and all sorts of different activities to increase registration of vaccines.
Thank you both. This has been really very informative. And I think you have many, many more things to share, as it was, it shows, Dani, there was a lot of data there. So my question is, and Sawsan, you just mentioned people want, you know, you have a lot to put into an instrument, but then you have to make this. So that is coming from my own interest probably, but I keep thinking about the education, the link between, you know, being so kind of obvious as an explanatory factor for what you were looking at for the behavior. So I kept thinking about health literacy and whether you had, you know, any proxies, even if you didn't measure health literacy, because even in highly educated groups on social media surveys, we found out that they're lacking in health literacy related to COVID, like COVID-related literacy. So it could be because it's novel or whatever, because of the misinformation, but that would kind of a question that I was kept thinking about. So if you have any insights, thank you.
Thank
you. We can look at the specific questions we have about knowledge about COVID, and think about what can be, you know, what can be defined as a health literacy question. I'm not sure. Yes, absolutely. We sort of, like when we were preparing the questionnaire, we were thinking about, okay, what are the questions about knowledge about COVID, and not framing them as health literacy questions, but we can revisit this and think about it. Absolutely. Yeah, I mean, the idea that education is not health literacy and health literacy is not education is very well taken, for sure.
We have one question from Asma Kordahi. Thank you, Asma, for being with us. It's an interesting question. Have you collected data on the population's original, the Syrian refugees, original place of residence, rural versus urban? And if so, did you observe a difference in adherence, even if both have similar levels of education? They have done studies in the past among Syrian refugees in relation to protection and health issues, and they observed differences based on background of coming from urban versus rural backgrounds.
Unfortunately, we had a limited number of questions we can ask in the survey. I think it was in our long list, location and origin in Syria, but we didn't include that in our shortlist, I'm afraid.
Well, we're out of time, but we have one question from the floor and one question from the Zoom group. So if colleagues are willing, I suggest we take those two additional questions. All right, well, we go to you then.
Yes, hi doctors, hi Dr. Steve, hi Dr. Sawsan. I am Mahmoud, I'm a PhD candidate from the School of Nursing. I'm currently working on predictors of influenza vaccine uptake among public transportation drivers, but I would like to share my experience in the past. I've actually worked on refugees and migrants in Jordan, and these were mixed population of Syrian, Iraqis, and other nationalities. Back to the question about gender differences, because I'm not sure if you found any gender difference in terms of COVID-19 precautions. Probably if you went to a younger population, like in the childbearing group, you would find that women are less likely to accept COVID-19 vaccines. And we cannot explain it by cross-sectional studies. You have to dig deeper, like run a qualitative approach. But from what we got from our population back in Jordan, we got some subjective feedback. They said that because men are the money-bearing or they are the breadwinners of the family, they mingle a lot with the population and they interact with others. So they put themselves at higher risk of contracting COVID, while women, because they are stay-home moms, they don't usually need it. That's the way they perceive it. This is number one. And the second, this population is very keen about the reproductive health. I mean, they are very concerned about the childbearing issues. They might be planning pregnancy or they are already pregnant, so they might delay taking the COVID-19 vaccine. That's why we observed a lot of gender differences on multiple aspects of COVID-19 vaccine hesitancy and uptake at the same time. Thank you.
That's very important feedback. I just want to say that our dream was to have an ILE student really do the gender analysis on the data. So we'll see, maybe we can get a student to help us and work on this. Or, I mean, now maybe we have more time and we can do it.
Okay. All right. The last question from the Zoom group, while looking into the psychosocial and structural factors impacting adherence and did ageism come up from the scarce research on older refugees worldwide and on older Syrian refugees in Lebanon? We know that ageism is an access barrier and a predictor of non-adherence even among healthcare, even when healthcare is free of charge. So perhaps one comment on that.
I mean, it's like gender, disability, ageism. Absolutely, these are all very important issues. And yes, we, you know, with more.
Come up as a was it a research concept? Was it a construct that came up in the context of
no. I mean, this is a quantitative study, and basically we didn't really ask about ageism. I mean, we didn't ask the participants if they feel that they experience ageism or that their lives are not important because of their age or no, because it was a structured survey questionnaire. Yeah.
The only place we might get at it is looking at you know, violence within and without the household, which we did collect. But again, we don't have a comparator outside of 50. So yeah, I think a larger study with a proper comparison group maybe is required for that. You could probably look in within the population where there's a difference between older and younger over the 50-year-olds, but I think we need a larger breadth of age to look at that.
Okay. So with this, we close. Thank you very much, Sawsan and Steve, and thank you, colleagues in person and online, for being with us. All right, take care.